Good morning, ladies and gentlemen. We are now opening our third day of the 18th Assembly held in Moscow. The 18th Assembly held in Moscow has already brought together more than 30,000 visitors. Can you imagine that? 30,000 people have come to learn about the advances in medicine, to get acquainted with the new technologies and new people. There have been 1,500 articles about the Assembly published, and we've had a multitude of various workshops and events. The third day of the conference is the most busy one. And of course, as part of our Assembly, we are summing up the competition of professionalism. The professionalism competition is organized by the Department of Healthcare of Moscow since 2015. The competition is called Life Formula. And according to our tradition, at the beginning of our session dedicated to primary states of immunodeficiency from early diagnosis to quality of life, so before we begin it, I'd like to give the floor to two amazing people who are also the moderators and honorary guests of our event, in order to award a diploma in the nomination Doctor, Immunologist, Allergologist. First of all, I'd like to introduce Anatoly Korsunsky, who is Doctor of Medical Sciences Professor, Honorary Specialist of Healthcare and Medical Director of Children's Hospital number 9, and Daria Fomina, Chief Allergologist and Immunologist of the Healthcare Department of Moscow. So, please receive a diploma on behalf of the Ministry of Healthcare and a statue. Can you say a couple of words, please? Good morning, dear colleagues. I feel quite excited today. It is exciting to congratulate a colleague with whom we work in the same hospital. There have been several candidates, and there has been a busy discussion of the winner among colleagues. But I think that if our patients were to vote, they would also choose this winner, Yelena Bobrikova. I'd like to invite her on stage. So Yelena Bobrikova is the best specialist in the nomination allergologist immunologist. Anatoly, congratulations to Yelena. A round of applause. Now, allow me to give you a kiss on the stage. And a picture. Let's make several pictures so that we can remember this amazing day. As I've mentioned already, I'd like to extend my gratitude to the award winners and those who helped me to deliver the award. And now I'd like to give the floor to our moderator. We are going to speak about primary states of immunodeficiency, from early diagnosis to quality of life. Thank you. Let us begin. Dear colleagues, academician Mr. Rumyantsev, who wanted to be here today, had to urgently go on a business trip yesterday evening, and he asked me to give a short introduction on his behalf. those who've had time to have a look at yet another revision of the international classification of diseases know that the number of diseases related to immunity deficiencies has increased there, and academician Rumensev thinks that approaches to many conditions that we are currently considering as conditions that are quite far from the immune system will have to be reconsidered quite quickly, because the next international disease classification will enter into effect in 2021, and we are going to work within this paradigm. So all of those present here today are in an advantageous position, because you will learn today something that other people will learn in a year. Now, primary immunodeficiency conditions, from early diagnosis to quality of life. This is quite a relevant subject today, and to some extent it is being considered by all the countries in the world. And we invited Professor Audrey Dan Galvin from the town of Cork, where she's professor of children clinic, but yesterday unfortunately she got flu and was hospitalized. That's why I would like to excuse her for the fact that she will not be able to speak, and I'm going to transfer her wishes of good health on behalf of the audience, because you can imagine that if in Ireland a person was hospitalized, that means that the condition of the person required that absolutely. Today we also have the Associate Professor of Imperial College of London, Daniel Mundley. We're going to ask him to speak. And now, in order not to spend too much time for introduction, I'm going to give the floor to Ilya Korsunsky, head of the City Pediatric Center of Immunology and Allergology. You have the floor. Thank you, Anatoly. Soon, ICD-11 will enter into effect, and what's important for us is that it will include all the immunological issues that are misrepresented there now. So soon we will be able to code the diseases of our patients in a better way. As of today and over the last 10 to 30 years, immunology has made huge progress. First of all, the immunodeficiency conditions, including primary immunodeficiency conditions, were recognized. It was understood that it's quite a common condition. People also understood that not all the patients die quickly. Many people live a long life, but it's not a life of very good quality. It's full of difficulties. Doctors started speaking about early diagnosis of those conditions, and early diagnosis is crucial for efficient treatment as well as good quality of life of our patients. As many other chronic congenital diseases, immunodeficiency and complications that happen to the person with immunodeficiency are irreversible. We can stop the disease, but we cannot reverse it. So our goal is to stop it as soon as possible and even cure it. Now, classification. Since we have mentioned that soon this classification will be publicly available, allow me to show how the primary immunodeficiency condition classification looks like. Just a second. I would like to briefly describe the issue that we are facing. So now we have more than 300 diseases or disease units, each of which is quite variable regarding the quality of life and outcome. Quite often, the same genetic deficiency leads to different genetic diseases. Often, there are two different genetic defects that lead to one clinical disease. Sometimes patients with the same immunodeficiency have a different course of disease and are treated in different ways. So we have the following scheme. It looks like this. This is the classification of primary immunodeficiency conditions. And we, as well as general practitioners and allergologists, immunologists, we need to understand whether the patient suffers from immunodeficiency, and if yes, what's the type of it. Primary immunodeficiencies can be classified by 9 groups. The main ones are humoral immunity defects. They are highlighted in green and represent more than 60%. That is, these are the issues with immunoglobulins and antibody formations. 15% are cellular immunodeficiencies, and some others include combined immunodeficiencies. As for the severity of conditions and prognosis, cellular and combined immunodeficiencies are the most severe. The children affected die during the first year of life, since they require bone marrow transplantation. If we're speaking about patients with humoral immunity deficiency, these are people who can live long until adulthood, but they go from one doctor to another since no one understands what's happening to them. As I've already mentioned, clinical manifestations of immunodeficiency are non-specific and very various. And there have been different lists with indices of immunodeficiency, and they are not specific. Mostly they are related to the frequency, severity, unusual nature of complications of infectious diseases. But we know that immunodeficiency is often manifested in the form of autoimmune, cancer diseases, and so on. Screening is what allows to identify the disease as soon as possible, ideally before any clinical manifestations. Screening includes 2 types. It can be selective or mass. Selective screening is screening in risk groups, for example, premature infants or infants with low weight. Speaking about mass screening, it affects all people. So every newborn is screened. Since in half of immunodeficiency cases there are no background factors, that is why we need to have total screening of newborns. What can we expect from screening? This is the data of our foreign colleagues, and we can see that the sample included more than 6 million of newborns, and the cellular deficiency screening has shown that 1 newborn per 4,000 is affected with T-cell lymphopenia. This is not all the time primary immunodeficiency, but anyway, this is a child with reduced cellular protection. That means that he needs additional examination to identify whether he has primary immunodeficiency or a primary condition that leads to secondary immunodeficiency. Or maybe he has idiopathic lymphopenia that doesn't require any action. But during this period until recovery, they need to be more accurate about the vaccination with live vaccines, at least. Speaking about primary immunodeficiencies, the frequency of T-cell immunodeficiencies is 1 per 2,000 newborns. This is 10 times more often than orphan diseases criteria, since it's 1 per 100,000. So once again, it's important. Immunodeficiencies are not orphan diseases. So, these 6 million children 1,500 of lymphopenias identified. 40% of them are cellular immunodeficiencies. 3% are other known conditions that lead to secondary immunodeficiency. I'm going to show what it is. 57%, that is to say more than half of conditions, are unclassified conditions, so we cannot determine what's this disease. We see some impairment, but we don't know what it is. Why am I speaking about that? Immune system is very sensitive. When we see some disruption in the immune system, through this disruption we can find not just immunodeficiency, but also something that was previously unknown by us. Speaking about primary immunodeficiencies, the epidemiology is becoming clear. It may be severe combined immune deficiency, known defects, D. syndrome. Speaking about patients with known syndromes, on the first place we have patients with Down syndrome. We have already suspected that such patients do have immune deficiency, and now we know for sure that they have congenital disturbances of cellular immunity. But we have a lot of children who cannot be really described. We can just describe their syndromes. And in this graph, I particularly like three groups: unknown, secondary, and others. So they are so varied, and it's impossible to classify them. So we immunologists are actually letting down other doctors, because we are finding patients not just for ourselves, but for other doctors as well. We also made our own pilot study about neonatal screening in the Moscow region, and out of 17,500 newborns, we identified 147 cases of T or B cell neutropenia. That is to say, reduction of T cell immunity. It doesn't mean that the child is ill. Sometimes it is in idiopathic conditions that goes off by itself. Out of these 147 children, 16 children had a pronounced reduction of T-cell immunity, and 3 children out of those 16 died of sepsis during the first 2 weeks of life, so their condition was quite severe. As for the other children, they are alive. They are a bit more than 1 year old today. All of them had serious lymphopenia. The first 6 months of life, it was identified by blood tests. Many of them have various syndromes, such as issues with cardiovascular system, digestive system, but that requires time, first of all. It requires time to understand what's happening to these children. For us, it was the first experience. And sometimes we can see that there is some issue, but we don't always know whether something needs to be done about it, and if yes, what exactly. So here is one of the documents of the study. Many Muscovites know this form. When we started doing the screening of primary immunodeficiencies and came with this idea to our leadership, the first question asked was, wouldn't it be cheaper to do nothing? Maybe it will be simpler for the healthcare system as well as for the financial system of the state. And actually the answer is not as simple as one might think. Almost all the screenings are deficitary, such as cancer screening, neonatal screening. It is quite rare but fortunately for immunology, immunodeficiency screening is not deficitary, but it is beneficial for the healthcare system.
And now, also, you can see that if you don't do anything, So if you don't do anything and you treat kids with immunodeficiency without diagnosis, they will die, and it's very expensive. It's much more beneficial to invest in the screening and to conduct expensive but efficient and short in time treatment. That's first thing. Even without screening, some children are detected, but not when they are born, but already when they already manifest some diseases. Earlier, we find these patients cheaper and more efficient to conduct such treatments as, for example, stem cell transplantation. You can see that the efficiency usually is better earlier. So even 1 month, 2 months baby can be treated already at a very early stage. And this is the accumulated table. If we detect immunodeficiency when a baby is born, and within 3 months we can do transplantation, so 94% survival. But if a patient is older than 3.5 months and doesn't have any disease, so already 9% survival. If has got already some disease, so 82% if he's ill, 50%, and 0 survival if we don't treat. If we speak about less heavy immunodeficiencies, these children without, of course, let alone life quality. So these children and then adults who go from doctor to doctor, always hospitalized, occupy beds, and get some benefit medications, also develop some chronic diseases. They always burden the system of medical health care, and of course they are not to blame, but we are to blame because we did not define their primary deficiency, immunodeficiency. We waste our resources, and then accordingly these people suffer. Thank you very much for your attention. And now dear colleagues, Ilya, thank you very much. I forgot to say to you that the format may talk make it possible to speak, sitting, but you made your presentation standing. Maybe because you respect our audience so much. Thank you very much for your presentation. Now I would like to give the floor to Daniil Moonblit. He will speak about this situation, and he works now in Sechenov University and the Imperial College London. The topic of primary immunodeficiencies is very important. Ilya has mentioned about screening, but screening about these conditions and also heavy combined immunodeficiency is already implemented in healthcare system. This is a part of routine practice, and let's hope that also in Russia we'll have it, because of course this is extremely important for patients and for their families to detect these conditions. Okay, screening is implemented. It's widely used in many countries. And so it's feasible. There are different methods of therapy. For example, intravenous immunoglobulins, also subcutaneous administration is good in some other countries, and the subcutaneous administration is even better for these patients, but unfortunately in Russia we don't use this administration methods. That's good news, and we have discussed it already today. We have hope that since summer we'll have the continuous immunoglobulin administration, and one company already will start to do this. That's fine. That's very good idea. So quality of life is very important for us, is a very important indicator. And we have conducted, with Ilya and my colleagues, we have conducted systematic review. In 2019 it was published. We looked at all research in the world dedicated to life, the quality of life of adults and kids with primary immunodeficiency conditions, and showed us some problems. How can we improve quality of life of children? We can support them psychologically, of course. We can. What tools can we use to measure quality of life? In many disciplines now, in many directions of medicine, we have this that patients. So we developed tools of quality of life, and we develop them as we think they're right. But when we give these tools to our patients, sometimes it leads to other effects. And lately, we also started to attract patients to evaluate the outcome of clinical research. And when we ask them, what do you think about quality of life? And they say sometimes we don't understand what it is. For example, many patients with atopic dermatitis don't understand the concept of quality of life. For them, it's much simpler to answer the questions whether I have some itchiness or whether I have insomnia. And now we are also reconsidering these approaches, how to evaluate quality of life, how to measure this. And as I see this, quality of life as a global notion is quite basic, especially for primary immunodeficiency conditions. And here it's essential that psychologists, clinical psychologists, should work with patients daily, and they know much more about patients than we clinicists and academicians and physicians. Thank you. Colleagues, Ilya, when he gave his presentation, he said that in Russia we have already a test to define immunodeficiency. It's already registered by Rospotrebnadzor in 2018. We were looking forward to this, and at all conferences, we were required to use this test. Now this day came. And since 2018, in our hospital, we have this opportunity to perform this test. If you want some more information about it, we will give Ilya minutes to speak about it. And now, maybe it will be interesting for you, anticipating this question. We now have an opportunity to conduct this test at our hospital, and for all our kids, biological material which sends to our lab is used to check this material, because we cooperate with association Solnuch под Solnuch, and we are trying to find sponsors, and that's why we can do this for free. So patients' blood comes to our labs, and we conduct this test. We don't, take money from these people, and this blood goes. So usually doctors sent us these blood samples. Unfortunately, a lot of children are already in extreme situations, very often in emergency departments, but still we want to have good diagnosis, precise diagnosis. That's why Daniil already spoke about this, and the Alexander Lunov, the representative of this charity fund, so-called Подсолнух, sunflower in English, and he will speak about his work at this charity foundation. Good afternoon, friends. I am a specialist, an expert working at the Charity Foundation. I'm a clinical psychologist. I'm the head of the psychological service of Подсолнух Foundation. And my presentation is called Quality of Life of Patients. And I will speak about correlation between patients and physicians. And what we as specialists think about this cooperation. And also I will speak about a psychological influence on children. Besides psychological influence, there are some other things which touch upon quality of life. But I will start from the general overview, and then I will continue to dwell on what is really specific for my work. This foundation, Подсолнух, was created in 2006, and we have been working with these patients with autoinflammatory diseases, autoimmune diseases, and immunodeficiency conditions. Also, we work with adults. We have several projects. And some projects are classical for charity foundations. One of the projects is available treatment. We finance different medical procedures, treatment, also medications, and also genetic research programs are included there, and all diagnostic procedures in which we participate. And besides, we have also some additional additional story, and we try to help our patients in complex. That's why also we have legal immunity project. These are our lawyers, and they solve issues regarding immune aspect, and also we have schools for physicians, and besides medical block, we also have legal block at these schools. I think it's relevant. Yesterday we had quite a big session regarding legal framework in medicine. And also we have two other projects which are more which are related to other things. This is Bright World, and this project is aimed at socialization, and I'm the part of this project, and also information project. This is so here we speak about. Here we inform people about these conditions, and also quality of life. So these are physical. This is a physical state functioning in society, some limitations, psychological and emotional conditions. And we try to work with all this. Also, we try to research what happens with our patients regarding these four areas. What research is it? Within the last 4 years, we have quite an extensive project. We fix all changes which happen with our patients, and some important things which patients pay attention to. And within this time, we had time to communicate with 200 adult patients and 300 families. And regarding children, and it's important to speak about this. Children, this is not the group which really can voice their needs. That's why here we need a complex approach. We should communicate also with parents and with the care providers. And we work in major Moscow institutions which treat primary immunodeficiencies. We also communicate with our patients remotely. Within this time, we conducted more than 44 schools in different regions of Russia. Now we have 13, and we also analyze all this data which we receive during some sessions at hospitals, and always we are communicating with our patients within different projects, and sometimes patients come to us and to our lawyers. In April this year, we conducted the Congress for our patients. We had a separate session at this Congress regarding quality of life. And these are the materials which are in the concept Nothing for Us Without Us. This is about patients with some conditions, and they also participate in this research. And these are the people who participate in our programs. This is our School of Physicians. We conduct these schools in different regions, as I've said, and we try to increase awareness not only of patients, people, general public, but also physicians. And this is the basics of the whole treatment. And at present, we have such a situation that we need to measure this indicate the quality of life, but sometimes it's difficult for this category of people because systematic review, and my colleagues mentioned about it, emphasizes absence of tools for kids. There is no some questionnaires for kids regarding quality of life. And also adult questionnaires which we have. So if we take traditional SF36, for example, it will not measure specifics, but still we have specifics. But foreign questionnaires are not really valid because they cannot be in compliance with our Russian reality. Because in small cities of Russia, patients face different realities than in abroad. And if we speak about stigmatization of immunodeficiencies, it's enormous because Moscow is exception here, not in all schools, but in the majority of cities we face this problem. The patient says, I come to healthcare clinic and the nurse saw my diagnosis and she called another nurse who can work with HIV and AIDS, and this is repeated all the time because parents always influence on other parents to get out kids from kindergartens with such deficiencies, and this is a real stigmatization, and this is very bad. And also wearing of medical masks is normal in Moscow, but if you work a salesperson in the village and you are wearing mask, everybody will be surprised looking at you. I work also in the at the Institute of Immunology with adults, and we we can see that some people come to us before diagnosis. They, you know, also had a lot of diseases before, but their quality of life was much better because they were perceived much better. They were perceived as not dangerous, and now they are perceived as a threat, and this also a stigma for them, and declines their life quality of life, because people can lose jobs even. And besides, this is also the parameter which is on the border of treatment and socialization. So people cannot work, you know, well, because if we administer immunoglobulins, in some regions, administration takes 7-10 days. So each month, a person should spend 1/3 of the month for this treatment, and of course he cannot work within this period of time. Or medications which cannot allow us to conduct these procedures at earlier stages. And I think that quality of life, of course, is worsening here because of such conditions.
Again, the matter of work is quite significant, and it is being discussed by almost everyone that we are communicating with. Now, regarding my work and regarding what we managed to identify with our colleagues psychologists, primary immunodeficiencies have a number of factors that affect people's psychology, patient psychology, and once it is established in childhood, it may accompany patients throughout their lives. In addition, even when diagnosis is made in adulthood, it is still there. First, we mentioned the newborn screening, and it is clear that in that situation, the goal of doctors and all of those who are working with the patients is to reduce the disability. So we capture the disease at the very beginning of life of the patient. The patient lives in a normal life. The genetic issues will remain, of course, but the situation overall will radically change. If the patient gets the diagnosis by 3, 4, or 5 years of age, usually there is a certain pattern of family relations already, and in future it will be quite rigid and it will be difficult to correct it, and in future it will accompany the child in adulthood and in his family already. There is also some non-specific impact related to the presence of a severe chronic disease. We may make a comparison with diabetes mellitus, for example, or with rheumatoid diseases, and the overall situation is similar. There are regular medical interventions. Quite often there is a possibility to end up in hospital. It's all very similar. But there are also things that are only related to the immune system troubles, and there is a very narrow group of factors, that is to say, neurological immunodeficiency syndromes. They are being researched into by neurologists. Neurologists try to correct them, but unfortunately, as of today, the situation is as follows. There is neurological treatment, but besides it, there are many things that could have changed the life of the patient, and I would like to start with them. D. George syndrome. Dear friends, who knows what is D. George syndrome in terms of its phenotype? Can you raise your hand if you know what this syndrome is? So, the George syndrome includes some immunological deficiencies. In addition, there are some impairments of other functions and systems, and it may also have serious physical manifestations, for example, face asymmetry or asymmetry in the skull. So the syndrome will be quite manifest. I haven't found a lot of publications in Russian literature about it, but the world experience shows that these patients are often affected by schizophrenia and epilepsy. And it's very rare that these patients see a psychiatrist because no one is trying to examine them for this matter, and it's not evident for the parents that it will be useful for the patient. The next syndrome is Niemann syndrome. It includes microcephaly and a somewhat elongated form of face. It is called bird face in medical literature, but the fact remains you will be able to identify this child by his physical particularities, and this is the particularity that is noticed not just by doctors but also by children in the kindergarten, for example, which may provoke stigma. And if no correction is done, it can also have further worsening. And our goal is to make sure that these children receive additional consultations and additional work with clinical psychologists or psychologists who would be able to include them into inclusive groups. And of course, psychiatric syndrome symptoms should be closely monitored. I would like to highlight a thing about the quality of life, since we are speaking about quality of life here. The quality of life increases significantly if comprehensive work is done. In my practice, I've seen kids who were not treated, and they grow up with mental retardation and very limited social interaction scope. So at best, they may find a work where they can just repeat routine operations. And in my practice, I've also seen children who were cared for, and it allows them to make a transition from an unfavorable situation to a more favorable one. Of course, initially these children are somewhat disadvantaged, but still they are able to go to school, communicate with other children, see some prospects for themselves, and those prospects will be quite realistic. That child will be able to go to work, to find a lover, to make a family, and there is a high probability that those differences will be unnoticed even by that person. There is also Lewy bodies syndrome. It is a serious impairment related to the gradual decline of various brain functions and destruction of brain structures. Unfortunately, this is a palliative situation, and adult patients with Lewy bodies are very rare. In the history of our institute, we've had just a couple of such adults, although there are many children that are born with this syndrome. But unfortunately, few of them reach adulthood. When I speak about decline of all functions, I need to make a remark. As of today, there has been no research that would confirm that, for example, speech that disappears at 7 or 8 leads to mental retardation, because by that time important speech functions could have been formed already. So perhaps we meet a child who cannot move his hands or write or speak, but intellectually he may be normal, and our goal is to understand how it actually works. And we are trying to include these patients into our inclusive classes. If these classes take place in a hospital, we include them into general groups. Of course, they receive special attention, but they should be included in regular groups so that they are surrounded by society. And just for the sake of experience and the possibility to be with other children. In addition, we are working with the parents in the family format. We are trying to unite families who could just take each other's experience so that families could watch other families who have children living with this syndrome. These are the pictures from one of our classes. Two families with the a child with the same Lewy body syndrome impairment. So children have difficulty walking, coordinating hands, fine motorics is impaired, motion apraxia is also present. It's difficult for them to focus their attention, and the gaze is sometimes not focused. But in one family there is one such child. In another family there are several children, for example 2 healthy children and 1 affected child, and we can see parents with children coming to the class and they receive a task of filling in a circle, and during the class in the family where there is one affected girl, she's trying to draw something, so she was trying to draw a carrot, and her mom told her, okay, I'll do it myself. So you want to draw a carrot? Okay, I'll draw you a carrot. You may put your hand on the sheet of paper, and she suggested that her daughter just makes a print of her hand, but the girl was 10 years old, so clearly her intellectual level was higher than that. And in the other family, where there are several children, the mom of that child said, okay, you draw your half and I will draw my half. And we got the second picture. And then during the discussion with the psychologist suggested the first family to try to allow the daughter to do something by herself, to give her some freedom instead of drawing a carrot instead of her. And the picture that you can see down is the second task, when the mother finally allowed her daughter to do something herself. So this is a typical situation that we can see at the classes that we conduct. Of course, one can work with it in life as well, but specialized care will be more relevant and will provide more resources. If I diverge a little bit from those severe syndromes, I can speak about immunodeficiencies in general. In general, still immunodeficiencies are stigmatized in this society. This is a complex disease. parents don't know how to speak about that. Social isolation is, of course, present. Wearing a medical mask also enhances stigma, and there is also self-stigmatization of parents who understand that they got an unhealthy child, and who is to blame for that? The correct answer is no one is to blame, but still parents sometimes try to understand who of them is the carrier of a wrong gene and so on, and many families fall apart actually because they fail to understand who is to blame. There are also grandparents, aunts and uncles who participate in those debates, and that raises tensions as well. One of the most particular things that is shown during classes by our patients are infringed personal borders. Parents always want to control what surrounds the child, whether the child feels warm enough and so on, and sometimes they may extrapolate this care towards the circle of communication of the child. For example, parents may tell their child, don't communicate to John because he always has leaky nose. And now I'd like to briefly speak about hereditary angioneurotic edema. This is a particular type of primary immune deficiencies, in particular regarding possible psychological assistance. First of all, there has been research that shows that there is a high probability of developing depression. In addition, patients often experience post-traumatic stress disorders because if they have a seizure that threatens life, they develop post-traumatic syndrome after that. And now briefly, once again, we have some group classes, individual counseling and patient schools that I've already mentioned. Now, regarding the results of work, we did some measurements after 1 year and 2 years, and it's clear that if there are more psychologists available in the clinics, patients tend to address psychologists. Sometimes patients participated in the program 2 times, as we can see on the graph. Regarding the stress level related to the disease, it's not very high, surprisingly, and it is reducing, but I think that there might be some inaccuracy there, because in reality I can see that the stress level is high. What increases significantly is the understanding of the disease and of the treatment regimen, because there is less stigmatization. It can be discussed with the child and with the relatives, and that reduces tensions. People start looking for information and discussing it. And to conclude, I'd like to say that together with colleagues, we issued methodological recommendations. You can receive them. If you come to our foundation, we will be happy to send you a number of copies. Regarding our plans and what's ahead, we are going to perform a study of quality of life with in patients with primary immunodeficiency. As I've already mentioned in the beginning, and as is clear from research, as of today, there is no valid questionnaire of sufficient quality. As here you can see our contacts. I will remain here. You may ask me questions. And thank you for your attention. Thank you very much. Your speech has been quite interesting. I think that for many it was interesting to listen to you, as many things were new for the people. Ilya, how can one make a test, and how can we get biological material of the patients that require examination?
Alexander, thank you very much for your participation. First of all, a lot of information, even for those who work with you. That's rather surprising. Regarding material, there are several ways. You can also apply to the charity foundation, for example, Pat Solnach or some other charity foundations, or you can connect directly with our Department of Paid Services, or you can go to our diagnostics department, and all forms of work, individual, contractual, are available for any person, and the material itself depends on what it is. If it's a whole blood, we are restricted because whole blood is available for analysis only within 1.5 days, and it should be in certain tubes with certain measures. If we speak about dry blood spots or artificial blood spots, in this case, this material can be sent even by mail. It's sustainable, stable, and doesn't need any special conditions. And you can learn about this in charity foundations with which we work, and also directly in our Department of Paid Services. And here I'm ready to answer your questions. Thank you very much, colleagues. Do you have other questions regarding our participants, the speakers? If no questions, we don't have any time more, but I have to make an entry, and I will announce our next Med Talk session, which will take place at 11 o'clock in the same room. It is through the same room, and the topic will be very intriguing. Interrelation between parents of babies, infants, and pediatricians and medical industry, which produces replacements of breast milk. We'll discuss this problem, how this is in the world and in our country. We'll try to understand these three directions which are needed for us, should not be in conflict, but now we don't have this. It will be interesting. The trick is very serious. Let's meet at 11 o'clock.